Hello doctors, welcome back to my channel, that is Asan Network. I am your Dr. Salahuddin, MBBS MS Orthopaedics, and let's continue with our fracture classification series. The next bone in our series is the carpal and the metacarpal bones. So what is the mnemonic for remembering all the carpal bones? We have learnt in our undergraduation, that is, she looks too pretty, try to catch her. Can you name all of it? First is scaphoid, then the lunate, then the triquetrum, then pisiform, trapezoid, trapezium, capitate and hamate. Okay, so can you locate all the bones from the radial side? This is the scaphoid, lunate, then the triquetrum. The pisiform is not visible here, it is present within the tendon. Okay, this is the trapezoid, this is the trapezium, this is the capitate, and this is the hamate bone. Okay, now we will be discussing the fracture classification of, first is our scaphoid bone. So coming to scaphoid fracture, the parts of the scaphoid are, it's a boat shaped bone and it has four parts. It has one proximal pole, then the distal most tuberosity, then a waist part and the body part. The peculiarity of this scaphoid fracture is that it has single blood supply coming from the radial artery. This radial artery gives two branches, that is dorsal branch and volar branch. 80% of the 80% of scaphoid bone blood supply is given by the dorsal branch, and also it is in retrograde fashion. This is the proximal most part and this is the distal part. So the radial artery will give a retrograde branch if the fracture occurs in this area. Then this whole part of the scaphoid will be devoid of the blood supply. Okay, that is why it is important. Now let's see the classifications of the scaphoid bone. So what is the first classification is based on the pattern of the fracture given by Roos, given by the fracture pattern, that is horizontal oblique fracture, a transverse fracture and a vertical oblique fracture. These three are given under the Roos classification. Next, depending upon the displacement and the stability, there are stable and unstable fractures. And undisplaced and then no step off in the fracture is a stable fracture. There are few criteria to call the scaphoid bone as unstable. What are those criteria? Number one is if there is more than 1 mm of displacement, if there is more than 10 degrees of angular angulation between the fracture fragments. Next, the third is the fracture comminution. Fourth is capitolunate or the radiolunate angle more than 15 degrees. Why this capitolunate or radiolunate angle is important is it forms the axis of the wrist joint. Okay, see, this is the radius bone, radial most side is the scaphoid and then the lunate. Upon the lunate is the capitate. Okay, then along the capitate is the third metacarpal bone. This forms the axis of the wrist joint. Okay, so you can imagine a saucer, a cup and a spoon. Okay, the saucer is the lunate bone, the cup is the capitate bone, and the spoon is the third metacarpal. So this forms the axis of the wrist joint. So the angle between radius and lunate should be less than 15 degrees. If it is more than 15 degrees when the scaphoid has been fractured and it has been moved or displaced, if it is more than 15 degrees, it becomes an unstable scaphoid fracture. Then the scapholunate angle, the angle between the scaphoid axis and the lunate axis. The angle between the scaphoid and the lunate bone, if it is more than 60 degrees, then also it's an unstable scaphoid fracture. And if the intrascaphoid fracture fragments are misaligned and they are having an angle of more than 35 degrees, then also it is an unstable fracture. Okay. Then based on the location, the proximal pole fractures, waist fractures, and the distal pole are the tuberosity fractures. In this, the most common scaphoid fracture part is the waist fractures. 80% of the scaphoid bone fractures are waist fractures. Based on the frequency, what pattern is highly most commonly occurring is the transverse fracture of the scaphoid is almost 50% of it. Next comes the horizontal oblique, next comes your vertical oblique. The proximal pole fractures are the least common fractures in the scaphoid bone. Okay. Another one most important classification of the scaphoid which was given by Herbert and Fischer is, see, Herbert and Fischer gave a classification based on the stability and chronicity of the scaphoid fracture. In this classification they have included the chronicity, that is the time duration of the scaphoid fracture, whether it's an acute or chronic fracture. Why it's important is, if it is an acute fracture, there will be more chances of blood supply to be intact and more early intervention can heal the scaphoid bone. And in a chronic fracture, that is the duration has been delayed, there is more chances of losing of the blood supply and more chances of getting a non-union. Okay, so here simply Herbert and Fischer divides it as A, B, C and D. So A is a acute, that too stable fracture. B is acute unstable fracture. C is delayed union and D is established non-union. Okay. Can anyone tell me what is the difference between delayed union and established non-union? What is union? Union means the signs of fracture healing, that is both clinically and radiologically have appeared within the normal duration of time. That is, if an fracture, like example tibia fracture, tibia shaft fracture, if we have to say it as united, so the signs of fracture healing should be appearing within the 4 weeks. Okay, if it takes more than 6 weeks and the signs of fracture healing appear at the 6th week, then we call it as delayed union, right? What is established non-union is, even after the 6 weeks, or according to FDA approved definition, specifically a non-union is said when the signs of fracture union, both clinical and radiological, have not appeared until consecutive 9 months. 9 months, if the signs of fracture union have not appeared, then it is an non-union. But it's different for different bones. Here for scaphoid, it's usually more than 6 weeks. If it appears, it's a delayed union. Still more than 6 weeks it has not appeared, then we may call it as an non-union. Okay. In the case of fracture neck of femur, when do you call it as an non-union? Please comment the comment section the time duration, when do you call it as an non-union. Okay, I will tell in the next, I will give you the answer in the next video. Now coming back to our Herbert and Fischer classification, So type A, that is acute and stable, it's divided into A1 and A2. Stable based on the fracture of tubercle, if it is fractured it's A1. A2 is an incomplete undisplaced waist fracture. Don't worry, I will show you the images, you will understand it better. We'll just see through the different types of the fracture patterns. So B1 is oblique distal third fracture, B2 is complete waist fracture, B3 is proximal pole, B4 is trans-scaphoid perilunate fracture dislocation, and B5 is comminuted fracture. Delayed union, that is persistent fracture line with minimal healing, is type C. Type C, simply you can remember it as chronic fracture that has been united. If it is not united and it's showing fibrous union signs, fibrous non-union signs, it's D1, and sclerotic pseudo-arthrotic signs, then it is D2. Okay. So in the image you can see acute stable A1 is only the tuberosity fracture is the A1, and if it is waist fracture, that too incomplete, A2. Okay. Then coming to B is B are unstable fractures. As we have discussed earlier, what are the criteria for unstable? So if one of these criteria is matching, and if it is an oblique distal third fracture, it's an oblique distal third fracture, it's B1. Waist fracture, if it is displaced, is B2. It's an displaced waist fracture is B2. The proximal third fractures is B3. We are coming from distal, mid and proximal. Then if it is an fracture dislocation, it's dislocated, then B4. Then comminuted fracture is B5. Now you can understand better, right? Now coming to C, as you know, C is delayed union. Beyond 6 weeks the fracture is united. Okay, the fractures ununited after the 6 weeks, but the signs of fracture healing are appeared. Okay, the signs of fracture healing are appeared at the 6th week, then it is type C. Still not appeared, it's a non-union, but if fibrous tissue is present between, it's a D1 fibrous non-union, and sclerotic changes are seen, it's a D2. What is this pseudo-arthrosis? So pseudo means false, arthrosis means joint. Simply in layman terms it is false joint. What does a true joint contain? True joint contains two bones. In between the cartilage, there is a cartilage, and there is synovial membrane and the capsule. So this is a true joint. Here it is a false joint. False joint contains, what are the two bones? That is the proximal and the distal fragment bones, proximal and distal fragments, and in between there is fibrous tissue. Here in the true joint there is a cartilage, here is the fibrous tissue, and a false fibrous capsule is formed. A false fibrous capsule is formed. False fibrous capsule is formed between the fracture fragments, hence it is called as a false joint. Okay. Another classification of scaphoid is Mayo classification. Simply there are 4 types in the Mayo classification based on the location and the stability of the scaphoid fracture. So distal most fractures, that is the tuberosity fractures, is the type 1. Then the waist fractures comes the type 2, proximal comes the type 3, and trans-scaphoid fracture dislocations comes in the type 4. Okay. Now tell me, based on this X-ray, what type of classification it comes. You have to tell me what Ruse type, what is its Herbert and Fischer type, what it is in Mayo type. Okay. First is identify the fracture line. So here is the scaphoid, this is the proximal pole and this is the distal pole. The fracture line is here. Okay, so first what based on the location, what it is, the location is, it's a waist fracture. As you know, 80% of the scaphoids are waist fractures. Now what type it is? It's an oblique or a transverse? It's a transverse fracture. Again, it's the most common pattern. So according to Ruse, it is transverse waist fracture. Okay. Now according to Herbert and Fischer, you have to identify first it is whether it is an acute or chronic. The fracture line is showing fresh fracture pattern, so it's an acute fracture. Okay. Now whether it's an stable or unstable, there are no signs of instability. The lunate is within the upon the radius. There is no increased radiolunate angle or no increased scapholunate angle. There is no increased intrascaphoid angle. Okay, so it's an stable. So what category it comes in Herbert and Fischer's? Acute stable comes as A. In the A1 and A2 are there. So A1 is fracture of the tuberosity, A2 is the fracture of the waist, and that too undisplaced waist fracture. Here whether displacement is present or not? No, there is no displacement here in the fracture pattern, so it's an undisplaced. So A2 type of Herbert and Fischer's scaphoid fracture. What type of Mayo classification it is? In Mayo there are 1, 2, 3 and 4. Okay, 1 is distal pole, 2 is waist, 3 is proximal pole. So it is an waist fracture, so it's an type 2 of Mayo's scaphoid fracture. Simple. Now let's continue with our next bone, that is lunate fracture. So who gave the classification for lunate? The Tyson and Heiserbach classification. Tyson and Heiserbach gave the classification system. The classification system, when you read it, it's a little bit hard to understand. See, he says frontal fracture and osteochondral fracture, frontal, transverse fracture in the body, then the transarticular frontal fracture. So it's difficult in text format. When you see the image, you will understand better. See, type 1 is simply the volar pole. When the lunate is fractured in the volar direction, volar and dorsal side. If it is fractured in the volar side, then it is the type 1. Okay, it is type 1. Then coming to type 2 is chip fractures. Small chip fractures occurring in AP view, then it's an type 2 type of lunate fracture. Then a dorsal pole fracture is a type 3. When the fracture occurs in sagittal plane, then it is an type 4 fracture, and if it is an occurring in transverse body fracture, it is type 5 of lunate fracture classification. Okay. Next we will go to the metacarpal fractures. Simply the descriptive classification says, based on the type of injury, based on the bone involved, based on the location within the metacarpal, then the pattern, displacement, deformity, the articular involvement and the stability. Based on the type, whether it's an open or closed, based on the bone, that is first, second, third, fourth or fifth metacarpal. Then the location within the metacarpal, the parts of the metacarpal is the base, shaft, neck and the head. Then the pattern is transverse, oblique, spiral, comminuted or vertical split fracture. Whether the displacement present or absent. Then deformity, if it is angulated or an rotational deformity. Then an articular involvement, whether it's an extra-articular or intra-articular fracture, and if it is an stable or unstable fracture. So this is the descriptive classification for metacarpals. For the open fractures of metacarpal, specifically Swanson, Swabo and Anderson, that is SSA classification of open metacarpal fractures. They gave this classification to know the rate of infection and to what type of treatment we have to give based on the infection. So simply there are two types. If the wound, that is the open injury, is clean and there are no contaminations, there is no delay in the treatment and the patient has no systemic illness, then you simply do an primary internal fixation and you close the wound immediately. Type 2, when one of the following is present, that is the wound has a contamination of dirt, debris, any bite mark, a barnyard contamination or warm water injury, and this is the first part of it. Then if the treatment is delayed more than 24 hours and the patient has like systemic illness like diabetes, rheumatoid arthritis, hypertension, hepatitis and asthma, the infection rate drastically increases from 1.4 to 14%. Okay, so there are high chances of infection, so you should delay the primary internal fixation. You should not do the primary internal fixation and you have to do and delayed closure whenever appropriate it is. Okay, this is the classification for open metacarpal fractures. Based on the part of the fracture, metacarpal fracture within the metacarpal, that is head, neck, shaft and base, there are two named fractures that are very important. One is Boxer's fracture and other is Bennett's and Rolando's fracture. So what is an Boxer's fracture? The boxers, whenever they give a punch, okay, the direct impact that occurs is at the metacarpal head. Okay, so if the metacarpal head gets fractured, then it's an Boxer's fracture and it may extend into the joint. Sometimes the neck fractures of the metacarpal are also considered as an Boxer's fracture. Okay, it's a dilemma. Some books give it as an neck fracture as a Boxer's fracture, some books give it as an head as an Boxer's fracture. Anyhow, we'll stick to Boxer's fracture is an head of metacarpal fracture which may have an extension into the metacarpophalangeal joint. Okay, here it's an joint, it involves a joint, so specific anatomical reduction is essential and very important for anatomical reduction, and you have to splint it in flexion of 70 degrees. Okay, you would in your day-to-day clinical practice you would have known, you will be doing a functional splinting like this. Okay, we will give a flexion of more than 70 degrees. Either you can fix it with an K-wire or screws. Okay, another important is Bennett's fracture and Rolando's fracture. What is Bennett's and Rolando's fracture is? It is the base of metacarpal fracture in the thumb. Within the thumb, the Bennett and Rolando fractures are present. So we will see why it is important. So in the base of the thumb, there are two types of fractures, extra-articular and intra-articular fractures. Both the Bennett's and the Rolando's are intra-articular fractures. This you have to remember, that is both Bennett and Rolando's are intra-articular fractures. The extra-articular fractures is it's just the metaphyseal area getting the fractured. Only close reduction and casting may be sufficient in extra-articular fractures. But in Bennett fracture, why it's important is it's an partial articular fracture and Rolando's is an complete articular fracture. Here there is a volar lip fragment and a major metacarpal disruption occurs at the carpometacarpal joint. Why? Because the abductor pollicis longus pulls the distal fragment proximally towards the radial side, and there is a dorsal displacement and supination of the distal fragment by the abductor pollicis longus, and also the extensor pollicis longus and adductor pollicis. These pull the distal fragment into flexion and head of the metacarpal into the palm. Okay, here will be this is the base of the thumb. Okay, base of the metacarpal thumb. If the fracture occurs, this will be pulled inside the thumb by the EPL and the adductor pollicis. I will show you in the image. Why this is important is, here no conservative management works. You have to do a close reduction and percutaneous spinning, or an open reduction or internal fixation, that has to be done. Okay, complete articular fracture, that is Rolando fracture, is a comminuted type of Bennett fracture, and there are two fragments, dorsal and palmar fragments, because it's an high energy trauma. Here also close reduction and percutaneous spinning is required. Why this displacement is occurring? Because of this muscle pulse. Okay, so you can see in the image, it's an partial articular is Bennett's, complete articular is Rolando's. So partial articular, here the dorsal and palmar in Bennett's fracture. This is the small chip, that is the partial articular area. This is the APL muscle causing proximal displacement, radial displacement of the distal fragment, and the EPL and the APL and the adductor pollicis longus will cause flexion of the head into the palm. Okay, so this will cause flexion and at the head of the metacarpal going into the palm. So because of this deformity, muscle deforming forces, you have to do an surgical procedure, that is close reduction and percutaneous spinning for Bennett's and Rolando's fracture. You can do a pinning, or you can put a open reduction and internal fixation with screws. Okay, so this is our carpal and metacarpal fracture classifications. So thank you doctors. Please like, share and subscribe to my channel for more updates in the classification series, and please stay updated with your classifications and do a great job in your clinical rounds. Thank you.